The reason for that is that there has been a lot of lack of awareness about pediatric endocrine disorders. So we started off with workshops and practical courses which were held across the country. Then we realized that it was very difficult to cover large areas because it is so much logistically difficult. So we started off with social media, particularly with YouTube. And then we started our fellowship program. Now we have got, today we have now got around 10th fellow. Dr. Dhwani has joined as well. So we have got now 10th fellow in our system who has joined the CDR program. Then we started off with our online courses and then finally textbooks and mobile applications. So we have tried to take forward in terms of making it easy and easily available and accessible in that regards. We have conducted a number of courses. The first practical pediatric endocrine course actually happened 10 years ago. So since then, we have got a lot of physical programs, but we also now have a lot of online programs which are there. So this is the third online program which we are doing because this provides a much wider access across the globe in that regards. We have our YouTube channel, which has got large number of videos which provide information about every aspect of pediatric endocrinology. There's also an online course which covers various aspects using validated tools. And we have got special courses, including the pediatric endocrinology for fellows, for postgraduates, fellowship in pediatric endocrinology, and a number of programs which are available online, which you can access through our website. We also run routine, regular postgraduate lecture series along with grand rounds using specific cases. So all these are concised in around 8 hours. These ones will run a long time and cover the entirety in that perspectives. And we have got publications which you can access and our mobile application, which will also showcase how it helps in terms of making point of care assessment and diagnosis possible. We are in the process of developing and probably will launch soon about our personalized intelligent EMR, which will allow our overall aspect of care using minimal inputs. Patients will get detailed output with regards to the likely diagnosis, likely evaluation and management. This will make connected clinics through using the e-system, making it much easier to whatever has been learned to implement in that regard. So recently, we have got a lot of programs. People have joined the fellowship program and the diploma program as well. So coming specifically on this international practical pediatric endocrine course, we have got this 2-day program. First day is dedicated today on office endocrinology. We'll be covering growth, thyroid, puberty, and DSD. And tomorrow we're going to cover the endocrine emergencies, mainly calcium, electrolyte decay, and hypoglycemia. So 8 modules. Dr. Saha from Dhaka, Dr. Chisholm, who is from Nigeria, and Dr. Rashmi Nagaraj from Mysore. Dr. Sain will be joining me to discuss the various cases with the 9% of all calcium in the body is in the bone, and only 1% of it can be exchanged on that. So bone is something which is actually storing it, but it's not very easy to give the calcium out. Now, out of the circulating calcium, around 40% is bound to albumin, 10% is bound to other anions like phosphorus, and around 50% is free, which is ionic calcium. So when we talk about hypocalcemia or hypercalcemia, we should actually look at ionic calcium and not total calcium, because that depends upon albumin. So especially in conditions like nephrotic syndrome, where the albumin levels may be low, or conditions like myelomas, where you may have high proteins, you may theoretically have a pseudo hypocalcemia or pseudo hypercalcemia, which may happen. The other thing which determines the binding of the calcium to the albumin is the pH. So in conditions which are associated with alkalosis, be they respiratory alkalosis or metabolic alkalosis, the anionic component of albumin goes up. Therefore, the free calcium goes down. So if you have a neonate who is hyperventilating, or if you have somebody who has a chronic renal failure who has a covert hypocalcemia, you give soda bicarbonate, you are raising the pH, you are raising the anionic albumin, you are reducing calcium. So alkalosis can therefore cause reduced ionic calcium and precipitate hypocalcemia. And this happens in hyperventilation and soda bicarbonate treatment, a very important point to consider in that perspective. Now, when we talk about calcium, we need to understand that there are 3 major organs which are regulating it. Bone is basically there as a store, but in acute states, it can provide certain amount of exchange. So it can really provide you immediately. So if you are in dire need, you can use your ATM to get the calcium out. The intestine is a chronic regulator. So you have long-term regulations happening through intestine, and kidneys do not play a very major role in calcium metabolism. but they can bear the brunt of calcium. So if you have too much calcium, you may have hypercalciuria and nephrocalcinosis. So acute regulation is largely done through bones. And like there are three organs, there are three major hormone systems which regulate the whole process. The most important of this is parathyroid hormone. Now, the parathyroid hormone regulates everything. It has an effect on the bone to get the calcium out from there. It has an effect on the kidneys to cause conservation of calcium. It also has an effect of increasing calcitriol production and indirectly causing an intestinal absorption. So PTH basically increases calcium by increasing bone resorption, increasing gastrointestinal absorption, and reducing the renal calcium excretion. Now, when PTH increases calcium, it also causes loss of phosphorus. So if you have high PTH, you will have hypercalcemia and hypophosphatemia. So if you have an individual whose calcium is high and phosphorus is also high, you cannot have hyperparathyroidism. Similarly, if you have low PTH, hypoparathyroidism or pseudo-hypoparathyroidism, you would expect that calcium will be low, but phosphorus will be high. If you have low calcium, low phosphorus, PTH abnormality becomes very less likely. So the major player is PTH. It has an opposite effect on calcium and phosphorus. Now, calcitriol is a major factor which regulates the intestinal absorption. The main role of vitamin D is to increase the amount of calcium which is absorbed by the intestine from around 20 to 30% to around 50-60%. So this is the only role vitamin D does, and it increases the blood calcium level. Now, vitamin D also increases the phosphorus absorption. So if your calcium goes up because of vitamin D, your phosphorus also goes up. So if you have conditions which are associated with vitamin D excess, you will have hypercalcemia and hyperphosphatemia. If you have vitamin D deficiency, you will have hypocalcemia and hypophosphatemia. So the most important investigation to be done in a child with calcium disorder is actually phosphorus, which will give you a clear-cut picture. Anybody with hypocalcemia, if they have high phosphorus, look at renal failure and look at PTH abnormality. Anybody who has hypercalcemia, has a high phosphorus, think of a vitamin D cause. This is something you need to evaluate from that perspective. Now, all this is sensed by the calcium sensing receptor. If this receptor becomes hyperactive, body will say, okay, your calcium is very high. It will reduce PTH causing hypocalcemia, but lose urinary calcium causing hypercalciuria. So hypocalcemia with hypercalciuria. If there is an inactivating mutation, you will have the opposite picture in which the PTH will become high, but kidneys are conserving the calcium. So you will have hypercalcemia with hypocalciuria. So when you have hypercalcemia, another important investigation is urinary calcium. And we'll show all those cases today when we are discussing about that, how these all relevant physiological tools become important from that perspective. So hypocalcemia, chronic hypocalcemia is very significant. We often miss it, but anybody who has seizures, cardiac failure, very important in the newborn period. Any seizures in the infantile period, definitely even beyond that, calcium should be looked at. One thing often missed out is ectopic calcification. So if you have basal ganglia calcification, it means there is a long-standing hypocalcemia. Similarly, uncontrolled headache could be benign intracranial tension because of hypocalcemia, stridor, and cataract. So any of these conditions you need to evaluate. Any newborn who is preterm, who is low birth weight, or who has a cardiac defect suggestive of DiGeorge syndrome, also we need to evaluate for hypocalcemia. Now, how do we look for calcium levels? Now, calcium levels should ideally be done in a serum sample using a fasting sample. The problem, as I discussed, is if your albumin is low, you will have a falsely low level of calcium. And if your protein is high, you will have a falsely high, pseudo-hypo and pseudo-hypercalcemia. Now, you have formulas by which you can calculate for every 1 gram decrease in albumin, you should add 0.8 milligram per DL. So this is the formula for corrected calcium, or you can get an ionic calcium, which is a more reliable marker in that perspective. Now, phosphorus again has to be done in the morning in a fasting state, because if you eat something insulin will be secreted, and insulin will cause decrease in phosphorus level because phosphorus will be pushed into the cells. The caution here is that do not use a tourniquet, do not squeeze, because it's an intracellular ion and it will come out and cause high phosphorus in a false fashion. And very importantly, use age specific level. Often you're giving reports in which you get the adult levels, but children have a higher level. So in infancy, you can tolerate phosphorus up to 8 milligram per dl, childhood up to 6, and adulthood up to 4.6. So very important, age-specific levels of phosphorus have to be looked out in that perspective. Now, very important thing to remember, we discussed yesterday about FT4 and TSH, that there is a log linear relationship. Similarly, there is a relationship which is sigmoid relationship between calcium and PTH. So what happens is that if your calcium is low, your PTH should really go up high. So anybody who has hypocalcemia should have a PTH which is very high. If your PTH is low or normal, this would mean that there is an inappropriately low level of PTH, which suggests hypoparathyroidism. So always look calcium and PTH, FT4 and TSH, glucose and insulin in the corresponding level that you actually look at the right time to assess in that perspective. Now, how do we approach hypocalcemia? I've already said that if you have to look at, first of all, other things like hypoalbuminemia, phosphorus load, and very important to look at magnesium. Anybody with refractory hypocalcemia, look at hypomagnesemia you want to evaluate. Look at phosphorus. If phosphorus is high, it is a very rare scenario. You're dealing with two things, either renal failure or you're dealing with a PTH cause. So if your creatinine is high, this is chronic kidney disease. If it's normal, look at PTH. You classify into hypo and pseudo-hypoparathyroidism. Now, one caveat is that if you have long-standing vitamin D deficiency, you may have a secondary PTH resistance. So if you have hypocalcemia with hyperphosphatemia and normal creatinine, particularly in an early age group, 2 months, 3 months, always do a vitamin D before you label them as pseudo-hypoparathyroidism. If your phosphorus is low, then you can look at vitamin D dependent causes, vitamin D deficiency or resistance. So this is what will be the rare scenario. So we'll now start off with the cases. Dr. Sayan will now start with the grand round, please.
Thank you, sir, for the introduction to the calcium disorders. Now, moving forward to the cases, this was a 4-month-old boy being treated for nephrotic syndrome, presented to us with a calcium of 7.2. Now, the child was asymptomatic on referral. Now, with the 7.2 being asymptomatic was I couldn't explain these symptoms. So, Dr. Anamika, can you just help me? A child of nephrotic syndrome, 7.2, but without any symptoms.
Thank you, Dr. Sayan. Well, in this scenario, a child with nephrotic syndrome having asymptomatic hypocalcemia, we should estimate the corrected calcium level and ionic calcium level first, because we already know that 40% of circulating calcium bound to albumin, and albumin is usually low in nephrotic syndrome patient. So in this patient, the albumin level, if we estimate the albumin level, is
in this patient it was low. Yeah, in this patient it was 2 grams per liter.
2 grams is as expected. The albumin level is low. So now we will measure the corrected calcium level. We know the formula, that is measured calcium plus normal albumin 4 minus measured albumin and into 0.8 milligram per dl. So the corrected level is 8.8, which is normal at this age. So the child had pseudo-hypocalcemia due to low albumin level. So the key message are, before initiating extensive workup for hypocalcemia, we should correct the calcium level according to albumin level. And ionic calcium is preferred to total calcium level to avoid the interference of these binding factors.
Yeah, this is a very important message, that ionic calcium should be preferred in such cases, as we can falsely label pseudo-hypocalcemia as true hypocalcemia. Moving forward to the next case. Now, this was a 4-year-old girl, hypocalcemia. This time we did ionic calcium. This was 3.1 and the child was symptomatic. Phosphorus very high. Phosphorus was 8.4. PTH was also high. So we think this case is a case of pseudo hypoparathyroidism. Do you agree, Dr. Chisholm?
Thank you, Dr. Sayan. Now, this case is an interesting case because for a child with hypocalcemia, the first thing you should expect is a low phosphorus level because of secondary hyperparathyroidism. But here we are having very high phosphorus level, very high PTH level with a presumptive diagnosis of pseudo-hypoparathyroidism. So the first thing to do anytime you get a phosphorus level that is very high is to assess the serum creatinine level to rule out CKD. So what was the serum creatinine level in this child, Dr.
The creatinine was 2.4.
And that is very high. So this child clearly has chronic kidney disease. And if you think about it, chronic kidney disease can give you hypocalcemia. Chronic kidney disease can lead to hyperphosphatemia. And at the same time, it can lead to secondary hyperparathyroidism. So it's more or less masquerading as pseudo hypoparathyroidism. So it's very important for any child with hypocalcemia, if you get a high phosphorus level, always check the serum creatinine to rule out CKD. And if the serum creatinine is normal, then you can entertain the possibility of either a PTH problem, either in function or in the creatinine, that's in the concentration. Thank you very much.
Yeah, thank you for this wonderful message. This is the message that Sir also gave, and Dr. Chisholm also wonderfully told us. If low calcium and high phosphorus, always rule out a CKD before moving forward to PTH. The next case, now we have a 1-year-old boy, again symptomatic, again low calcium. The phosphorus is doing normal. Again, PTH is low. And in spite of repeated admissions, we give him IV calcium. He responds for that moment, but immediately after going back from the hospital, he starts again to seizure. So, Dr. Rashmi, is it the straightforward case of hypoparathyroidism not being treated adequately?
Thank you, Dr. Sayan. Good afternoon, dear all. Actually, here it's a frank case of hypocalcemia, which is not responding to IV calcium. And parath hormone is little towards lower limit of normal. So the next thing we have to think about is do a magnesium, because any intractable hypocalcemia or a refractory hypocalcemia, after giving adequate doses of calcium gluconate, that is 1 ml per kg per dose, diluted 1:1, if it's not responding, always think next magnesium. So what was the magnesium?
The magnesium was 0.42 milligrams per deciliter in this case.
So it's quite obvious that there is clear-cut hypomagnesemia and the magnesium level is quite low. So in this case, since magnesium is important for the release of parath hormone, and hypomagnesemia can clearly cause hypocalcemia. So we have to correct hypomagnesemia in the first place by giving 0.2 ml per kg of 50% max self IM.
Yeah.
But this seems to be severely low, actually, the magnesium levels.
This problem started very early.
Yeah, and also the problem has started very early, and the magnesium level is also significantly low. So probably we may have to think of a genetic defect here also.
Yeah. And his elder brother also had same problems, and we did a genetic test, and this is what came out.
Yeah, this is actually a TRMP channel defect, 6-channel defect. These channels, when they become non-functional, they hinder the intestinal absorption of magnesium, and also they increase the urine output, the urinary excretion of magnesium. So it's a permanent problem. So this requires administration of very high dose of magnesium, and relieve the symptoms, we may have followed by a lifelong oral magnesium supplementation. So always the key message or take-home message would be here. Always in refractory hypocalcemia, think magnesium first rather than anything else, and treat it. Thank you.
So, Sayan, what were your challenges in this case? So we were giving magnesium at what dose, and what is the problem in these cases?
Sir, the problem initially was that when we gave IM magnesium, it rose immediately. But when we transferred to oral, it again fell. We actually had to give around 16 times the normal dose to this patient.
Normal requirement maybe 22, so you need to give around 10 grams of magnesium every day. So we were using a magnesium sulfate solution for the injection and breaking it and giving it. So it's a very, very difficult, challenging condition. They are not absorbing any magnesium. They are losing magnesium. So how do you maintain it? It becomes difficult. But now the child is doing pretty well in terms of seizure free. We are able to cut down on the anti-epileptic drugs as well. So again, a big message, think hypomagnesemia in that scenario.
Yeah. Thank you, sir. Thank you, Dr. Rashmi. Now, moving forward to the next case, a 3-month girl, again symptomatic, again having seizures, and this time again we have a low ionic calcium. The phosphorus here is low. So a low calcium and a low phosphorus, but the PTH is low. So a low calcium and a low phosphorus with a low PTH, I think we can't match this case along with the diagnosis of the referral physician who labeled it as hypoparathyroidism. So Dr. Chisholm, do you think this is hypoparathyroidism?
Thank you, Dr. Sayan, for this case. Again, a very interesting one. And yes, I understand why you would think it's hypoparathyroidism, but then again, there's a problem here. The phosphorus level is low and the PTH level is low. That's not in keeping with what is expected. Remember, in hypocalcemia, you expect the PTH level to go high, and conversely, when the calcium level is high, you expect the PTH level to come down. So at this point, okay, if there's hypocalcemia, if the PTH level is high, always consider the possibility of secondary hyperparathyroidism. So for the assessment of this child, everything is pointing or leaning towards a vitamin D deficiency. So when the vitamin D was assessed, what was the value, Dr. Sayan?
Yeah, the vitamin D was undetectable in this case.
So that's very, very low. Clearly, this child has a vitamin D deficiency. But remember, the phosphorus level is low. So why is the PTH value also low? I expect it to be high. So I requested for another PTH value, and it turned out that it was actually high. So we discovered on further investigation that the serum that was assayed or collected for PTH was improperly stored. It wasn't transported in ice. Remember, PTH is very thermolabile, very sensitive to heat. So if you must assay for PTH in any child, in any individual really, you must transport that blood on ice. Otherwise, you're going to get an aberrant result. So always remember, in hypophosphatemia with hypocalcemia, it means that the PTH level is working. It can be low. Although if it's low, you may actually think it's hypoparathyroidism if the blood is properly transported on ice. So this is the take-home message here. Always transport your serum on ice. And if you get a low phosphorus level with hypocalcemia, always think of PTH level only when everything has checked out well. Thank you very much.
Thank you, Dr. Chisholm. This is the most important message. If not taking care of the pre-analytical issues before doing the investigations, we can have such confusing reports. So thank you. Moving forward to the next case, we have a 1-week boy, seizures, low ionic calcium, very high phosphorus in this case. Creatinine now, as Dr. Rashmi said in the next case, we did creatinine in this case. So CKD was ruled out. Low calcium, high phosphorus. So Dr. Anamika, what do you think in this case? Very early onset.
Well, this neonatal boy having hypocalcemic seizure with hyperphosphatemia and creatinine is normal, so already exclude chronic kidney disease. So next step is measuring parathormone level. And what about the parathormone level?
Yeah, PTH was 2.
So it's low.
Yeah.
It's low. So the child is having hypoparathyroidism. And one of the important cause of neonatal hypoparathyroidism is Dijor syndrome. So when we get a patient with neonatal hypoparathyroidism, we should look for the important signs of this syndrome, like cardiac defect, dysmorphic faces, especially cleft lip, cleft palate, immunodeficiency, or absent thymic shadow, although it may be absent in stress neonate also.
Now, actually, this patient did have a cardiac defect.
So diagnosis is, as the patient has already cardiac defect, so our provisional diagnosis is Dijor syndrome, and it can be confirmed by FISH study.
Yeah.
So key message is,
yeah,
hypocalcemia with high phosphate level indicates parathormone defect. And if when we get a patient with hypoparathyroidism, it's mandatory to evaluate cardiac function.
So this patient, Sayan, comes to you with complaints of respiratory distress, and you find that there is a pneumonia. What precautions will you take in this case?
So, respiratory distress can occur due to low calcium and also.
No, he has pneumonia.
Yeah.
And you have admitted in the ICU.
Yes.
What should you do, Vibha?
So first of all, in isolated water, we should be kept away from the infected children, and we should be given immunoglobulins.
So I think we often tend to focus only on the endocrine aspect. So we actually had lost a case like this who have been managed outside, with this scenario. So Dr. Anamika was mentioning about immunodeficiency. So you have to look at the total leukocyte count. The leukocyte count actually was, I think, nearly 0 in that case. So in that scenario, you have to isolate them, role of IVIG, as we were discussing. Dr. Anamika, your inputs?
Yeah.
So Dr. Anamika has already said that we should think of immunodeficiency in that scenario.
Thank you, Dr. Anamika. Moving forward to the next case. This was a 10-year-old boy presented with seizures. Now, there was a low ionic calcium, but in spite of that, due to the seizures, the referral doctor went ahead with the CT. And this is what he found. And this is what we have on presentation, a low ionic calcium and features of ectopic calcification. So, Dr. Rashmi, can you take us forward from here? Any other thing that we have to think of in this case?
Sure. It's a 10-year-old boy. The scenario is with seizures and most probably hypocalcemic seizures. And so along with hypocalcemia, if there is calcification, first thing maybe we have to think about is some parathormone related cause. So on clinical examination, this child also was found to have cataract. Then he was found to have brachymetacarpia and subcutaneous calcinosis. So all these features are very much suggestive of, could I know the phosphorus level, Dr.
Yeah,
Sai?
phosphorus was very high.
Yeah, so this scenario with a high phosphorus level, a low calcium level definitely looks like a parathormone defect, unless we have ruled out CKD, and here creat was 0.4, so definitely we have ruled out chronic kidney disease. And of course, parathormone was quite high. So despite the high parathormone with high phosphorus and low calcium, we should think of a pseudo-hypoparathyroidism. So this kind of clinical presentation, especially with intracranial calcification, always think of a parathormone defect. And always look for other features suggestive of that, like brachymetacarpia and subcutaneous calcinosis.
Yeah.
Thank you.
How will you manage this case?
We'll manage because PTH isn't acting. We'll manage with the final product. We'll give calcitriol and calcium.
And what is the difference in terms of management of hypoparathyroidism and
We can
pseudo-hypoparathyroidism?
maintain a higher level of calcium in this case.
So you have to maintain a higher level. In hypoparathyroidism, you have to be cautious because the urinary conservation is not there. So if their calcium goes beyond 8.5, 9, you will have hypercalciuria. While here, because the PTH is acting in the conservation area, you can maintain a higher, you have to maintain a higher level, otherwise the bones will get resolved. So remember, in hypoparathyroidism, the target is around 8.5. In pseudo-hypoparathyroidism, the target is around 9, 9.5, and the treatment again is calcium and calcitriol.
We have a 4-week-old boy now. Seizures, ionic calcium again very low. Phosphorus in this, phosphorus now is very high. Low calcium, high phosphorus, normal creatinine. So Dr. Rashmi, kindly take us forward from here. Again, is this hypoparathyroidism? Dr. Rashmi?
Yes, sir.
Yeah, is this pseudo-hypoparathyroidism now?
So
4-week-old boy.
It's a 4-week-old boy, almost at the end of the neonatal period, and phosphorus is towards the upper limit of normal, but creat is normal, and parathormone is significantly high. Even though we may think of, right now we may think of a pseudo-hypoparathyroidism, we may have to think more common cause like vitamin D levels. Was the vitamin D level done in this?
Yeah, vitamin D levels were very low in this case.
Yeah, so in view of the almost normal phosphorus levels and phosphate level and low calcium, vitamin D level is expected to be quite low, and it was significantly low in this case.
Yeah.
And despite the secondary hyperparathyroidism here, calcium level is significantly low. So we may also have to think of a parathormone resistance here. Because phosphorus level still remains on the higher side, and calcium level continues to be low despite the secondary hyperparathyroidism. So this is a combination of vitamin D deficiency with a likelihood of parathormone resistance. So the key messages here would be always check vitamin D levels before diagnosing a pseudo-hypoparathyroidism. And despite high parathormone levels, if the calcium is still low and relatively high phosphorus, always think of a parathormone resistance.
Yeah, a wonderful message by Dr. Rashmi. And this is what CERT always tells us. PHP won't present this early. When a child presents this early, always think of secondary secondary PTH resistance due to vitamin D deficiency, and always do a vitamin D before labeling a child with PHP. Moving
Why
forward,
does vitamin deficiency cause resistance, PTH resistance?
so post-cyclic AMP problems.
Why? What is the concept behind it?
So because how much more will the PTH take
So
out from the bones?
basically what is happening is, no. So basically PTH is too much, but it is not able to convert to calcitriol. The major hypercalcemic effect of PTH is basically through the gut. But if it is not able to increase calcitriol, all everything is getting wasted. So body says, okay, I will not allow further PTH action. So long-standing vitamin deficiency, particularly in infancy, but you reported also in that young child also, vitamin deficiency can cause hyperphosphatemia. So although the rule is that hypocalcemia, hyperphosphatemia, normal creatinine, high PTH equals PHP, you should consider vitamin D before that. That's a big message which Dr. Rashmi gave very clearly.
Moving forward to the next case. Now we have a 5-year-old child. Symptomatic, total calcium very low at 5.6. Phosphorus is very high. Creat was normal. So Dr. Chisholm, is this case different from the previous one?
Yes, Dr. Sayan, it's actually very different because if you look at the creatinine level, it's within normal. So I would like to know what the PTH level is right now. And
PTH
the
was
PTH
very
level, yes, I can see that. So this is indicative of hypoparathyroidism. So at this point, I would like to start the child on calcium calcitriol. And was the child started on calcium calcitriol?
I'll just add one thing. When this child presented to us, we also saw this. The child was much more pigmented than his family members. And this was actually increasing over time.
Oh, I understand. So I think at this point, I would like to point out that if you find a child that you suspect or you've confirmed to have hypoparathyroidism, it's very important to rule out cortisol deficiency, adrenal insufficiency, because that will be one of the most likely cause of hyperpigmentation in this child due to an increase in ACTH. So at this point, when you're giving the child calcitriol and calcium, before you commence treatment, it's very important to rule out cortisol deficiency. So what was the...
Now, Dr. Chisholm, when this child was actually treated by the referral physician, he gave him calcium and calcitriol. And
what
when
was the
this
case?
child
was the
presented to
cortisol
us...
deficient in this child? Hello?
Yeah.
Can you hear me?
Yes.
Yes, when the calcium and calcitriol was started, so what was the response?
When this child presented to us, he was very sick. And when we did the calcium levels, it was actually found to be high, very high.
Oh, interesting. So at this point, it's possible that we should do a serum electrolyte value. And what did we get after doing the serum electrolyte?
There was actually salt wasting and cortisol was very low, as you were mentioning.
Exactly. So it's indicative of a likely disease called autoimmune polyglandular syndrome, because in this disease, you have multiple endocrine abnormalities. In this case, we have hypoparathyroidism, there is adrenal insufficiency, which is in keeping with hyponatremia, hyperkalemia, hyperpigmentation. So the key message here is that if you're suspecting hypoparathyroidism in a child, it has been confirmed really. Always rule out autoimmune polyglandular syndrome because cortisol deficiency must hypocalcemia. So if you start treatment without ruling out cortisol deficiency, you're going to end up with hypercalcemia. So it's very important in any child with hypoparathyroidism to always rule out cortisol deficiency before commencing treatment. Thank you very much.
I think that's a very, very important message because the most common cause of older children who present to us with hypoparathyroidism is actually APS. If you look at it, most of us between 1 to 5 years of age turn out to be APS. Beyond 5, they look like more like idiopathic hypoparathyroidism. The other big message that Dr. Chisholm gave is that if you have cortisol deficiency, it will basically cause hypercalcemia. So if you have reduced calcium requirement in the setting of hypoparathyroidism, if you have reduced AVP requirement in the setting of central DI, if you have reduced insulin requirement in the setting of type 1 diabetes, you should always exclude cortisol deficiency. Because cortisol deficiency causes hypercalcemia, it causes a SIADH-like picture, it causes a hypoglycemic picture. So cortisol deficiency should always be considered in this scenario, and that becomes important in that regards. So we have discussed a lot about hypocalcemia. I'll go a bit about rickets because that's very important. And we all know that rickets is basically a disorder in which you have an effect of the growing plate. You have got cupping, fraying, as well as playing. Now, all this is because of a problem of growth plate apoptosis. Your growth plate is not apoptosing, and the agent which causes growth plate apoptosis is actually phosphorus. So everybody who has got rickets has a phosphorus deficiency. This is what you need to understand. Now, once you see rickets, you can then need to start treatment. Regarding treatment, there are various guidelines available, the global recommendations. These are from the Indian Academy of Pediatrics recommendations. Remember, we are not talking about very, very high doses. We are typically talking about more like weekly doses at the maximum of 60,000 international units. No role of injections. The injections are only indicated if you think of malabsorption or if you think of celiac or something like that scenario. Very importantly, whenever you give vitamin D, give calcium, because otherwise the bones will take all the calcium and you will have hypocalcemia. That is known as the hungry bone syndrome in that regards. Now, once you start treatment, remember, calcium may go down, as I said, because bones are using the calcium now. ALP may go up because ALP is a marker of bone formation. You may have more bone pain because bone is being formed. So all these are not markers of inadequate response. So what is most important is the line of healing. So you have to show that the lining healing is there. If it's not there, it is a refractory rickets. So how do you define refractory rickets? Of course, you need to prove that this is a metaphyseal involvement. You may have skeletal dysplasia which looks like rickets, and you may confuse that, okay, this is refractory rickets. Adequate treatment, 2 courses or at least 6 to 8 weeks of vitamin D has been given, and there is no line of healing which is there. However, if a child is polyuric, has seizures, fractures, and severe growth failure right at the beginning of presentation, you may consider, okay, this may be a refractory rickets right in the regards. Very importantly, you may misdiagnose refractory rickets if there is skeletal dysplasia, if you do not give enough calcium or vitamin D, or if the alkaline phosphatase levels goes up and you say it is refractory rickets in that regards. Now, as I said, everybody with rickets is phosphopenic, low phosphorus. But broadly, we classify into ones because of deficiency of phosphorus, which are late presentation, predominantly with lower limb involvement and normal parathyroid hormone levels. This is typically hypophosphatemic rickets or Fanconi syndrome. You can have problems of either the vitamin D, the entire axis are known as calciopenic rickets. Now, in calciopenic rickets, also the phosphorus levels will be low because you have secondary hyperparathyroidism, early onset with tetany and hyperparathyroidism. Now, you can have vitamin D deficiency, you can have calcium deficiency, you can have liver disease, anti-epileptics, kidney disease, and VDDR. The most important investigation, therefore, in a child with rickets is phosphorus. If your phosphorus is high, you are dealing with either a kidney problem or you're dealing with a problem of pseudo-hypoparathyroidism, which may resemble right rickets in that regards. And finally, you can have acidosis, which is not really a disorder of the bone. It's basically eluting the bone, and their RTA can be the cause. You will have failure to thrive, polyuria, and nephrocalcinosis. So the investigations to do is phosphorus. If phosphorus is high, think of renal failure and PHP, urinary calcium. Everybody with rickets should have a low urinary calcium. If you have a high urinary calcium, you're dealing with renal tubular acidosis. PTH again should be high in everybody who has rickets. If it's normal, this is hypophosphatemic rickets. ALP should be high in most. If it's normal, think of RTA or chronic kidney disease. If you have low alkaline phosphatase and rickets, that is a very rare scenario of hypophosphatasia. You will have 20, 30, that level of ALP. And acidosis, of course, will be there with RTA or chronic kidney disease. So the most important investigation is phosphorus, high phosphorus, renal failure, or PHP. Then calcium, if it is low, along with hyperparathyroidism, you are not dealing with hypophosphatemic rickets. So a low calcium or a high PTH excludes hypophosphatemic rickets. That will be an easier way to understand. Everybody else should have hypocalcemia or hyperparathyroidism. Hypercalciuria suggests a renal tubular acidosis, and acidosis, of course, discussed about RTA as well as renal failure. So the key investigations are phosphorus, calcium, PTH, and pH. These will give you the major picture, plus you add urinary calcium. So you look at the phosphorus. If phosphorus is high, most likely kidney disease, rarely PHP. Otherwise, give an adequate trial of calcium and vitamin D. If there is no response and phosphorus is low, blood gas will diagnose RTA. If calcium and PTH are normal, it is hypophosphatemic rickets. Otherwise, they are VDDR1 and 2. So phosphorus, blood gas, and PTH. These three will give you the diagnosis. So we'll start there from their side.
Thank you, sir, for your brief on rickets. And moving ahead, now we have a 3-year-old boy presenting to us with rickets. We had given him 3 doses of vitamin D weekly, 60,000 international units. Now the child presented to us after 3 weeks with complaints of increasing bone pain. Now, when we repeated the ALP, it had gone further high. Calcium came out to be normal, and we were suspecting refractory rickets in this case. Dr. Anamika, do you agree that this is refractory rickets now?
No, Dr. Sayan, because we just learned from the lecture of Anurag sir that bone pain and high alkaline phosphatase can be normally present during treatment of vitamin D. So they are not gold standard marker for the response to therapy. So to see the response to therapy, we should go for X-ray of left wrist to find out the line of healing. Yes, there is a present, there is a thick white line at the metaphyseal end of the long bone. So there is a normal response to treatment. So this is wrongly diagnosed as refractory.
And this is how sir also corrected me at that point of time. And anything else you want to mention?
Do you need
do you need any correction in this case? Because the child was also having deformities.
Although bony deformity usually correct with treatment with vitamin D therapy, if it's not happen or child is getting older, in that case, we can refer to orthopedics for orthopedic correction.
Yeah. Thank you so much. Very important point, as you mentioned. Yeah. Now the key messages you want to deliver.
So key messages are that is line of healing is the best marker for identifying the response to treatment, and not confused with bone pain or increased ALP as a marker of response to treatment actually.
Thank you. Thank you for this message, Dr. Anamika. Moving forward to the next case, we have a 4-year-old girl with rickets. Now I had given her adequate calcium, 5 ml BD, that comes out to be 500 milligrams per day. But after recalling the child, I found no improvement, even after 30 days. I repeated the X-ray. There was no line of healing. So I thought of refractory rickets in this case. So Dr. Anamika, do you think this is again a correct diagnosis, or am I missing something?
Well, to identify refractory rickets, we should focus on treatment with adequate dose and duration of treatment with vitamin D. You have only given calcium and no vitamin D. So, first of all, we have to give vitamin D in adequate dose and duration. And according to the global recommendation, the daily dose of vitamin D is 2,000 units per day for infant and 3,000 to 6,000 units per day for children, along with calcium supplementation. And the treatment should be given minimum 3 months. So we can say that the child is inadequately treated. So to identify
parenteral vitamin D in this case.
Sorry?
Would you prefer any IV or IM vitamin D in this case?
Well, there are different modalities of treatment of rickets. There is a weekly therapy can be given, but single dose or weekly therapy is discouraged to prevent vitamin D toxicity. In that perspective, oral therapy is more encouraged.
Yeah. And parenteral would be given only in case of malabsorption.
And would you
in case of malabsorption, in case of malabsorption, we can prescribe weekly IM therapy. In that case, the dose will be 60,000 units for 6 weeks, actually.
Would you be considering, Dr. Sayan, calcitriol in this case?
So calcitriol, I haven't treated him adequately. If the child had seizures, then I would have thought of it. So
you need to remember that the analogs of vitamin D are very, very toxic because they have got a very high potency and a short half-life. They can cause hypercalcemia. The only role, as you said, is hypocalcemia. Otherwise, no role. So don't give all the preparations which contain calcitriol in this scenario.
Yeah. So the key messages, Dr. Anamika?
So the key messages are to diagnose refractory rickets. First of all, we should ensure completion of treatment with adequate dose and duration of vitamin D along with calcium for 3 months.
Yeah, thank you. Thank you. Moving ahead to the next case. Now we have a 4-year-old girl with rickets. Vitamin D, we had given her 2 courses, but there was no improvement of the same. Now, when we were suspecting refractory rickets in this patient, we also asked her about the associated symptoms. And in this case, the child had abdominal pain and anemia. So Dr. Rashmi, does this give any clue to other causes of rickets in this case?
Yeah, this is a 4-year-old child who has not responded to vitamin D D courses, of course, 2 complete courses. And she also complains of abdominal pain and anemia. So we may have to think about malabsorption syndromes here. And since she has abdominal pain, probably we may have to think of conditions like celiac disease. So in such cases, we may have to dig into the history further, asking for any other GI symptoms, look for growth failure, and look for healing line on the X-ray. If there is no healing line, then it is probably not responded to the oral vitamin
Dr.
D.
Rashmi, this patient was given parenteral vitamin D. So do you agree with this line of management? Dr. Rashmi?
There seems to be a response to parenteral vitamin D, which will suggest that this was in fact malabsorption. So of course, as Dr. Rashmi was suggesting that we should get a TTG, another evaluation for celiac done. So it was strongly positive. So the key message would of course be that if you have anybody who has GI symptoms, anemia, think of celiac, evaluate.
Moving ahead with the next case. Yeah, Dr. Rashmi?
Yeah, could you please?
Yeah, you can give us the key messages in the previous case. Yeah. Moving ahead with the next case. Now, this was a 5-year-old girl, had rickets, had complaints of polyuria along with. Weight and height was very low. Height age and weight age was around 2 years. Now, on a VBG, she had metabolic acidosis and a urine pH, which was very inappropriate for the level of blood acid. Now, this was diagnosed to us as a case of RTA. Do you agree with this preliminary diagnosis, Dr. Chisholm, based on this report?
Yeah, Dr. Sayan, before I can agree with that diagnosis, I would like to check the phosphorus level. Can you tell me what it is in this child?
Yeah, the phosphorus level was 9.
Okay. And what was the serum creatinine level?
The serum creatinine was 2.
Okay, so 2 milligram per DL of creatinine suggests chronic kidney disease. So I'll walk along those lines, manage this child with chronic kidney disease. Again, like I mentioned earlier on, chronic kidney disease can give you a picture that is similar to hormonal problems related to calcium metabolism, like reduced PTH and whatnot. CKD in this case can give you metabolic acidosis. It can give hypocalcemia, high phosphorus levels. So address the CKD and then everything will work out fine. So the key message here is that for a child with hypocalcemia, failure to thrive, high phosphorus level particularly, always rule out chronic kidney disease because that will help save that child from doing a lot of unnecessary investigation. It will also save costs. So high phosphorus level with features suggestive of rickets, hypocalcemia, always think chronic kidney disease. Thank you very much.
Yeah. Thank you for this wonderful message again, that we have to look into the primary causes and not the secondary causes of tubulopathy, as you very rightly pointed out in this case. Moving ahead to the next case, we have a 12-year-old girl now. So later onset, having multiple fractures, but now on asking her further, she said her parents complained that she was having failure to thrive, polyuria and myopathy, and features suggestive of myopathy. So Dr. Anamika, any special thoughts to this case?
Well, this girl, we see from these 2 pictures that this girl have severe bony deformity as well as a fracture on X-ray. So the line of investigation should be calcium phosphate and alkaline phosphatase level. What about the phosphorus level?
Yeah, phosphorus was 2.1 in this case.
2.1, which is low, and creatinine 0.6, that is normal, so it's exclude CKD. So next, as phosphorus is low, so next step is serum electrolyte and blood gas.
The blood gas showed metabolic acidosis, pH of
Metabolic-
7.1.
Yeah, metabolic acidosis. So our we divert to renal tubular acidosis. To differentiate between proximal and distal, I would like to do urinary pH.
Yeah, so
And
the urinary
it's very
pH,
high.
yeah, it was 7.4.
So so metabolic acidosis with rickets and high urinary pH, all of this indicates this case of distal RTA actually.
Yeah. So the key messages now, Dr. Anamika?
So key message are when you find a child with failure to thrive, polyuria, having rickets and fracture, consider distal RTA one of the cause of rickets. And
Yeah.
okay, thank you.
Okay, so thank you for this wonderful message again. So later onset fractures, always think of distal RTA in a case of refractory rickets. Moving ahead to the next case. Now we have a 14-year-old boy, again with refractory rickets. But in this case, we see a more lower limb involvement. So Dr. Rashmi, do you think any other cause of the same, predominant lower limb involvement, a later age of onset?
Yeah, this is a child with quite old to have rickets. So probably the nutritional causes could be ruled out. And he's got a predominant lower limb deformity with upper limbs almost paired. So the one thing we may have to think here is probably a low phosphorus, hypophosphatemia. So what was the way I would like to do the phosphorus?
As you just said, the phosphorus came out to be very low.
Yeah, according to this algorithm, in cases of hypophosphatemia, we may consider doing a blood gas subsequently, and blood gas is
came
here.
out to be normal.
Yeah, this was found to be normal. So then we would like to do a calcium and parathormone level.
This is the calcium, it was 9. And
yeah, calcium is normal, parathormone is normal, and low phosphorus.
Yeah.
So it's a classical hypophosphatemic rickets with late onset and predominantly involving the lower limbs.
Yeah.
So the diagnosis, so the take home messages would be whenever there is normal parathormone levels, normal calcium levels, and predominantly lower limb involvement and late onset, always think of a hypophosphatemic rickets and so treat accordingly.
Yeah, thank you for this wonderful message again. If there is only low phosphorus with normal PTH and normal calcium, we always have to consider hypophosphatemic rickets.
So now we'll go to the final aspect of hypercalcemia. Now, hypercalcemia should be suspected, especially in units. It's a sick scenario if you have severe dehydration, polyuria, and hypotonia and encephalopathy. So any sick child, check calcium. That is a big message. And in children, again, with abdominal pain, uncontrolled hypertension, and if you have calcification at any point of time, or of course, if you have metabolic bone disease. Now, hypercalcemia theoretically can be because of two disorders, as we discussed, either if your bone turnover is more because of hyperparathyroidism primarily, or you have increased absorption, that is blast because of vitamin D related causes. So if you have hyperparathyroidism, typically your phosphorus will come down. If you have a vitamin D related cause, your phosphorus will be high. So again, phosphorus is a key investigation to look at. You can rarely have decreased excretion, which is not very common. Calcium sensing receptor defect, which is causing an inactivating mutation, will have a scenario in which you have hypercalcemia with hypocalciuria. So phosphorus and urinary calcium will give you a diagnosis, and hyperparathyroidism is classically the most common cause to look at in this group. While if you have other thing very important to remember is a lytic lesion. So in children, if you have acute lymphoblastic leukemia, you can also have hypercalcemia, which may happen. If there is immobilization also, you will have less amount of bone turnover, as also happens with hypophosphatasia. So if your alkaline phosphatase is less, you are not using your phosphorus. You will have in that scenario, hypocalcemia will happen. And if your vitamin D absorption is increased, And if you have increased uptake, you will have a similar scenario. Now, if you're in that scenario, your 1-alpha hydroxylase will be low. If there are granulomatous diseases like sarcoidosis, tuberculosis, as well as fatty necrosis, you can have increased expression of 1-alpha hydroxylase that also causes hypercalcemia in that regard. So these are the conditions you should think of in that regard. So I will say mainly think of hyperparathyroidism, vitamin D excess, that is very important, granulomatous disease, and a calcium sensing receptor defect. So what you have to look at is phosphorus. If phosphorus is high, this is PTH independent, as I discussed. And of course, PTH in somebody who has hypercalcemia, PTH should actually be low. If your PTH is about 20, that is high. So this is inappropriately high. You start thinking of a hyperparathyroidism. Urinary calcium, everybody with hypercalcemia should have hypercalciuria. But if your urinary calcium is low, this is a calcium sensing receptor defect. And again, vitamin D will also give you a clue. If it's very high, it is vitamin D excess and calcitriol in that scenario. As discussed, hypercalcemia, your PTH should be less than 20. If the PTH
Oppo A57
Hemang, can you mute it, please? So if you have hypercalcemia, your PTH should be less than 20. If your PTH is more than 20, it is suggestive of hyperparathyroidism. So approach is, if PTH level is below 20, look at vitamin D. If it is high, this is vitamin D excess. If it is normal, you look at calcitriol. If calcitriol is high, it is granulomatous disease. If it's normal, this is hypophosphatasia. If the PTH level is about 20, so even if it's normal, you look at fractional excretion of calcium. If it's high, this is hyperparathyroidism. It is less, it is calcium sensing receptor defect. So essentially, the main message is to look at phosphorus levels, and then based upon that, you look at vitamin D level, which will give you a diagnosis. Hyperparathyroidism, do a urinary calcium, which will give you a clue. So Sayan, you can now carry it forward with the calcium issues.
Thank you, sir. Moving forward to the next case on hypercalcemia. So this was a 12-day-old girl presenting to us with irritability. She was very dehydrated. Now just look at the calcium levels. Calcium was 18 in this case. Dr. Rashmi, what do you think of a girl presenting so early with such a high calcium level?
Yeah, this is a newborn baby with severe hypercalcemia. So we must think of most commonly genetic defects here. And she has very well presented with dehydration because polyuria is one of the manifestations. So I would like to do a parathormone level in the first place.
Yeah.
And yeah, it was
120.
Yeah, it was found to be sky high actually. Yeah. It's quite elevated. And next thing would be to do a urinary calcium, as Anurag sir very clearly mentioned. Yeah. So urinary calcium creatinine ratio of 0.3 is reasonably okay. That is, I mean, there is no hypercalciuria at least. So if it is like in hyperparathyroidism, if there is hypercalcemia, as sir mentioned, there should be hypercalciuria also. But here, calcium excretion in the urine is almost normal. So this must be something to do with the calcium sensing receptor defect. So the thing is, it's not sensing it. It's assuming that the calcium levels are normal. So calcium is not excreted in the urine. So this causes severe neonatal hyperparathyroidism, and which is an acute emergency. In fact, it has to be addressed immediately, surgically, probably. Otherwise, we are going to lose the baby.
Yes.
So the take-home messages would be, whenever we generally always think of hypocalcemia in a newborn baby, and we generally never consider hypercalcemia. So whenever there is a polyuria, irritability, dehydration, seizures, encephalopathy, always think hypercalcemia. And in this, a very young age presentation like this would prompt us to think about a genetic defect, especially the calcium receptor, the sensing defect of the calcium receptor.
Yeah.
So
thank you, Dr. Rashmi, for this wonderful message. So we can also consider blood investigation in the parents also.
Yes. Yeah. So that will give you a.
Yeah. Sure. So moving forward to the next case, we have a 2-year-old girl now with complaints of abdominal pain. Now the ultrasound was done due to abdominal pain, showed nephrocalcinosis. Calcium was then done. Calcium came out to be high. 13.6. Now, the phosphorus here is also high. So, Dr. Chisholm, is this a PTH problem? Dr. Chisholm?
This is a scenario in which.
Can you hear me? Hello?
Yes,
Yeah.
Okay, so thank you for that presentation. So I'd like to point out quickly that this is like a reverse of what we've been doing so far. This is a child with hypercalcemia, hypophosphatemia. So it inevitably means that the PTH level is appropriately low. Otherwise, you would have been thinking that there's a problem with the PTH. So at this point, the PTH level, what was it in this child?
PTH was undetectable in this case.
So that's what it should be. It should be low in a situation of hypocalcemia. At this point, I would like to check the vitamin D. What was it?
The vitamin D was very high at 200.
Yes. Yeah, that goes without saying. This vitamin D level is so high. And at this point, I'd like to make a diagnosis of vitamin D toxicity. So at this point, I would like to point out that in a situation of hypercalcemia, remember, in hypercalcemia, the PTH level should be low. And the one way of noticing this is that the phosphorus level should also be high. And that was what was in keeping here. So the next thing that we should do is to check for any vitamin D excess. So in this case, the vitamin D was equally high, giving room for vitamin D toxicity. So at this point, I would like to counsel the mother to stop intake, giving this child vitamin D. I would also like to point out that the key message here is to always remember that once there's hypercalcemia, hyperphosphatemia, always think of a problem with vitamin D. In this case, an excess. It can't be PTH problem. It's unlikely to be. So for the hypercalcemia, hydration with furosemide to enhance excretion, and of course, steroid treatment is necessary here to achieve normal calcium level. Thank you very much.
Thank you for this wonderful explanation. Again, which sir also mentioned, high calcium, high phosphorus, think vitamin D. High calcium, low phosphorus, think of PTH problems. Moving forward to the next case, we have a 15-day girl, preterm, 28 weeks of gestation. Calcium, again, very high at 14. Now, you check the phosphorus here. It came out to be pretty low for this gestational age. PTH, we did, considering the primary PTH problem. It was here undetectable. So, Dr. Anamika, any other cause of this? Could you please guide us here?
Well, this preterm baby having hypercalcemia with hypophosphatemia and parathyroid is also low. So my next step of investigation is vitamin D level. What about the 25D or calcitriol level?
Yeah, 25 hydroxy vitamin D was 20 nanograms per ml.
Yeah, it's a lower end, and calcitriol 125 is a higher end. Is there any history of taking total parenteral nutrition?
The child is very sick and on TPN.
Okay, it's a common scenario of a preterm baby having TPN, having this low phosphorus level due to decreased supplementation of phosphorus. And this low phosphorus level increase 1-alpha hydroxylase action, which increases calcitriol production, ultimately increasing hypercalcemia. So that these baby having hypophosphatemia. So
yeah, kindly go ahead with your key messages.
And key message are hypercalcemia with very low parathyroid level exclude hyperparathyroidism, and hypophosphatemia can be itself a cause of hypercalcemia.
Yeah, due to high calcitriol, as you just mentioned, and this case very well demonstrate this case that the actual cause of hypercalcemia is low phosphorus due to TPN, as you wonderfully mentioned, Dr. Anamika. Thank you. Moving forward to the next case. Now we have a 2-month-old boy presenting to us with fractures. Calcium, again, very high at 14 milligrams per deciliter. Phosphorus at 6.8. PTH here is undetectable. So, Dr. Anamika, any other thing that you would like to consider in this case?
Well, this boy having high calcium and high phosphate with low parathyroid level. So again, next step is measuring vitamin D level. Yeah. And vitamin D both are low. So as vitamin D also low. So my provisional my diagnosis, it may be a disorder of bone turnover, as patient has already high calcium and high phosphate. And
so also did an ALP, it was 24.
Yes. So next to diagnose the disorder of bone turnover, my next step will be alkaline phosphatase level measurement. And as it's low, so it indicates it's a case of hypophosphatasia.
Yeah. So, what are the key messages
So,
that you'd like
key
to give?
messages are high calcium and high phosphate indicates low bone turnover, and low along with low alkaline phosphatase level indicates hypophosphatasia.
Yeah. So again, a wonderful message contrasting from the previous case of vitamin D excess. After ruling out vitamin D excess, always do a ALP, because as this case shows, hypophosphatasia can also present with similar complaints. So thank you, Dr. Anamika. Moving ahead with the next case. Now we have a 4-day-old boy presenting to us with seizures. Now this child had a history of asphyxia. Calcium very high at 18 milligrams per deciliter, phosphate doing fine. PTH we did was undetectable. So Dr. Rashmi, does asphyxia signify anything in this case?
Yeah, the background of asphyxia in a newborn baby with significantly elevated calcium and relatively lower phosphorus and almost negligible parathormone. So looks like a parathormone independent cause of hypercalcemia.
Yeah.
So we would like to do next would be vitamin D level, which was found to be normal. So according to the algorithm, next would be to do a calcitriol, which
So calcitriol was very high.
Yeah, significantly high. So maybe we may have to examine the baby to look for any other clues.
Now there was multiple violet nodules in this patient.
Yeah, maybe that may suggest fat necrosis because this calcitriol high, it could be a granulomatous problem. When there is a palpable nodule, violaceous, tender skin nodules in the newborn baby with a very high calcitriol levels, we have to think of fat necrosis. So this may be a most likely cause of hypocalcemia in this baby.
Yeah.
So the key messages would be always consider fat necrosis with nodules and very high calcium in a newborn baby with a background of asphyxia, because it's relatively common and we may have to look for that. And the treatment would be to give proper hydration, steroid and diuretics like Lasix.
Yes, yes. Thank you, Dr. Rashmi, for this wonderful message again. So moving forward to the next case, this is a 3-year-old boy presenting to us with complaints of bone pain. Calcium was done very high at 14.4, phosphorus doing fine again. Again, PTH is undetectable. Now, vitamin D and calcium, as the protocol shows us, these were again normal. So, Dr. Chisholm, any other cause of this we can think of apart from the vitamin D dependent and the hypophosphatasia that can cause the same?
Yes, there's something that I would like to think of, but then again, I want to draw the viewer's attention to a particular issue here. This is a child with hypercalcemia, and ideally you expect the phosphorus level to be high, but it's low. So at this point, what can it be? So the PTH level is equally low as well. The vitamin D level also low. Calcitriol within normal range. So what can it be? At this point, I'd like to do an X-ray of this child, and it indicated that there were lytic lesions in the bone. And what was the alkaline phosphatase level, Dr. Sayan?
Yeah, it was very high.
It was very high. Well, at this point, I would like to do a bone marrow aspiration, because remember, apart from the hormonal issues that we know that is associated with calcium metabolism, it's very important to rule out other sources as well. So a bone marrow aspiration, what was the result?
The bone marrow aspirate showed a huge number of atypical leukocytes.
So suggestive of acute lymphoblastic leukemia.
Yeah.
It's very important for us to understand that there's some malignancies, in this case, ALL, I'm going to work with that can actually cause an invasion of the bone. So when there's an invasion of the bone with malignant cells, it increases osteoclastic activity, and that can lead to hypercalcemia. So when you assess this child, done several investigations, and it's not tallying with what is expected, there's low PTH, there's low vitamin D, calcitriol, similarly within normal level, always think outside the box. Always examine, think of the possibility of leukemia. And in this case, this child actually had acute lymphoblastic leukemia. So that is my take-home message. Think outside the box when it doesn't fall into place. Thank you very much.
Thanks a lot, Dr. Chisholm, for this wonderful discussion. And we are now discussed exhaustively over the last 20 cases of calcium in this 1 hour. So we were able to cover the entirety of it. I'd like to thank Dr. Anamika, Dr. Rashmi, and Dr. Chisholm, along with Dr. Sayan, for making it really interactive and completing all those aspects. We'll take a few questions which are there. So there is a question from Dr. Ajib Das, who says that nutritional rickets 7-year-old with bony deformity, what will be the duration and dose of vitamin D and calcium? So the initial one will be to correct it. So this may be required for up to 3 months. So this can be done as a daily dose, or you can do a weekly dose. After that, we would like to look at the bone of healing, whether that's there or not. And the second would be to look at continuation with a maintenance dose of calcium as well. Dr. Gayatri is asking weekly vitamin D or daily vitamin D. So vitamin D daily is of course better, but then the issues of adherence may be there. So in that case, you can think of a weekly therapy, but preferable will be a daily dose. Dr. Karthik is asking for prevention of rickets. Do we need to give calcium supplement or vitamin D alone? Usually calcium deficiency is not that important, especially in younger age group. So vitamin D alone may be good enough, especially in breastfed individuals. Dr. Bharani is asking, this could be hypophosphatasia as condition also cause fracture tendency. Yes, we have to consider that as a possibility as well in that scenario. So if you have high calcium, high phosphorus fractures, low bone mass, think of hypophosphatasia as a possibility.